Hi, my name is Christopher Cox, and for the second part of my video, I'm going to talk about weaning. Our patient here, Miss Stevens, we're trying to extubate her. But before I extubate her, I want to look at her ventilation and oxygenation status invasively. I can do this because she has an art line in. I can draw blood from that art line and see my numbers and see if I'm happy with them. I can also monitor her ventilation and oxygenation non-invasively by means of capnometry and SpO2. Capnometry will give me a good estimate of where her PaCO2 is, and her SpO2, if I have a good wave form, a good pleth, I can look at those numbers and see where her sats are. There are other patient assessment skills I can use. I can look at her heart rate. Has it increased? Is she tachycardic? I can look at her blood pressure. Has it increased? Is she showing signs of cyanosis? Is my patient stable? Well, guess what? Miss Stevens is stable. So we're going to wean her. We're going to flip her over to a totally spontaneous mode. Dr. Smith told me to put her in spontaneous pressure support, 5 PEEP, and 5 pressure support, FiO2 of 30. Alright, so we have her switched over now, and now she's going to be doing all the work herself. I can now get some numbers from her. First, I can look at her spontaneous tidal volume, which happens to be 250 milliliters. Now the range is 4 to 6 milliliters per kilogram. She happens to be 50 kilograms, so if you take the 4, that's 200. If you take the 6, that's 300. So she's smack down in the middle at 250. Next, I look at her respiratory rate. Her spontaneous respiratory rate is 14, which is less than 30, so we're happy with that. I can now calculate her Tobin index. I take the frequency and divide that by the tidal volume. So I take the 14, divide that by 250, and I get to be 56. We want the Tobin index to be less than 80 to 100. This Tobin index helps us to see if our patient is breathing too rapid or too shallow. If it's too rapid, she's going to tire out. If it's too shallow, she's going to build up her CO2, and we're going to have a big problem. Next, I look at her vital capacity. Normally, we would want the vital capacity to be 4.8 liters. Hers happens to be 3.6 liters. But what we have to take in mind is that she has COPD. So we know she has a problem getting air out. So the 3.6 liters is good for her. Next, I look at her NIF, which helps me to see her muscle strength, her respiratory muscle strength. It happens to be negative 45. We usually want anything over negative 20. So that's more than double of what she's supposed to have. So we're happy. I report these to Dr. Smith, and he's happy. Now he wants me to non-invasively measure her oxygenation and carbon dioxide levels. So I look at her SpO2 on the monitor, and it's 90%. I look at capnometry, and it's 60. This is good because it's close to her baseline ABG of 55 for her PaCO2. She is ready to be extubated. Now my next video, I'm going to talk about BiPAP administration. Now for my sources for this video, I used our clinical manifestations book and also ccmtutorials.com. Thanks for watching.